Well, good morning, everyone. We're so grateful that you're joining us today. I'm sorry for the weather, Chris. I know I already apologized, but I just wanted to reinforce that. And Chris, I loved what you put on your last slide, which may have passed by folks very quickly, but it was the quote from Aristotle about the purpose of knowledge is not knowledge, it's action. And that is what we're here to talk about today. I'm incredibly grateful to be surrounded by colleagues who I've worked with, and there are many others in the room and outside of the room, to be able to turn what we know is necessary for safety into meaningful action. And we've had the chance to partner in a number of ways with Craig, who we'd love to have with us, and we're so grateful he's joining us virtually, but is co-chair of the National Steering Committee for Patient Safety, along with me, and then with the engagement over many years of real pioneers who are taking some of what we've created through that work, aligned it with national initiatives, and are turning that into action itself. So let's get started so we can get the richness of the expertise of my colleagues on the screen and hopefully leave you, or have you leave here with at least one very clear thing that you'll be doing to take ideas from the blueprint and translate those into meaningful action to improve safety. In a couple of sessions, we've used some polling questions because we've wanted to get a clear sense or a better sense of what your familiarity is with what we'll be talking about today. And we invite you, I know as I said yesterday, they're always kind of close to hand, but pull those up because we're curious to learn a little bit about what you know about a couple of the main blueprints, inputs that we're talking about today. And the first is the Safer Together National Action Plan and the organizational assessment tool more specifically. Some of you may be hearing about it for the first time at this meeting, and the architecture of this meeting is really around the foundational areas of the National Action Plan. And others may have a lot of work underway to be able to translate what's needed for safety into action using that blueprint. So we invite you to share a little bit about where you're currently entering the conversation with us today. Wow. All right, so looking like there's some great opportunity to kind of open up some of the doors of awareness and appreciation around the Safer Together Action Plan and specifically the organizational assessment tool. Seeing some nice work underway with several of you who are responding, and we're really curious and invite you to be co-partners in producing and advancing work in safety using the blueprint for those who might be sitting next to you who may be just starting out in that realm. Let's follow that up now with your understanding or appreciation of the Centers for Medicare and Medicaid Services Patient Safety Structural Measure. Again, some of you may be on the front end of, hey, it's news to me, I'm just hearing about it, or it may be something that's well underway, particularly if you're within the United States, although there's very clear relevance and benefit for those of you who may come from the outside of the United States for some of the structural and cultural practices in that plan that are associated with safety. Wow. Okay. And how many of you, I'm going to take my glasses off so I can see a little bit better for this one, because this is the manual poll. How many of you who are here have responsibilities for working in acute care hospitals within the United States or any of the cancer hospitals for which the patient safety structural measure is relevant? Can you raise your hand so we can get a, okay, so there's probably, what do you think, 50% or so of folks who are at least exercising their arms this early in the morning. so we'll go from there. But it's nice to see that we've got a fair percent of you that are familiar and are socializing it and are conducting an assessment. And we realize that there are some in this room for whom that is not applicable. So let's thank you for laying the groundwork on that. I think we've had a beautiful tee up in the conversation we're having now with the conversation that started yesterday with Dan Heath when he was talking about the reset, which is what I think about when I think about the work that we're talking about today. And he talked about, and we were talking about yesterday afternoon, embedding safety in the daily work of the organization. And I'd like to connect the dots, at least in my mind, about the beautiful synthesis and alignment of the conversations that we've had so far. So let's get started. For some who are not aware, I wanted to just make you, lift some of the awareness that a system assessment of safety is noted in the aligned initiatives of what we just talked about with the National Action Plan self-assessment and with the patient safety structural measure. And Craig will be talking a little bit about how that comes together in the integrated work of a lot of our federal partners in the Department of Health and Human Services. They talk about Safer Together as a critical blueprint for being able to conduct and assess and identify those areas for action. And I'd like to get some input from Kelly and Angie and Craig overall about how you see this kind of coming together. And why it matters. Let's talk about why it matters, first of all, for the work of safety. Want to start?
Sure. Well, for me, I see a patient safety assessment as an opportunity for safety to get to the table where quality's been. You know, bringing metrics and data forward in a way that it hasn't traditionally been. And why I think the National Action Plan matters, and probably why it's actually vital to progressing in patient safety for our future, is that it digs around in the DNA and in the foundation of what can make up a robust patient safety framework. And it brings that to the table, but not just to the table as the health of what it is, but with a roadmap to improve. So I think that is essential for our future.
Thanks, Kelly.
So for us, the National Action Plan and the Blueprint has really been a way for us to understand what is the infrastructure for patient safety, right? So when we talk about that blueprint, it's really not about what work we're doing, but it's about how we're doing the work. And what we've realized over time, and I think many of you have heard throughout this, is we've made tremendous improvements, and we can knock it out of the park when we put our minds to something, but those don't sustain over time. And the reason that those things don't sustain over time is because we haven't really grounded in that foundation or that infrastructure about how to sustain change. So when we think about what we learned in that self-assessment and how we're using that, if you ask anybody in the room from Ascension, what is the National Action Plan, they likely can't tell you, and they likely can't recite all of the components of it or what that maturity model looks like, because what we've done is just ground it in how we do the work. So when we're rolling out new initiatives or we're talking about our HRO culture work and those tactics, we make sure that the elements of maturity from the National Action Plan, right, that guide us in the infrastructure, are included in each and every one of those implementation plans. So we release it from that perspective, and I think that's what's going to help us change the way that we transform safety work over time.
Thank you. And before we jump into here, Craig, I just wanted to clarify, Angie and Kelly, tell us a little bit about where and how you're using it in the organizations in which you work.
Sure, yeah, I think each of us offer a different perspective.
Yes.
I'm a director of ambulatory quality and patient safety, and I'm not a senior director. So my work was more like grassroots as part of a project that I started for my IHI fellowship last year. And so my approach to it is much different than Kelly's. So how we're using it now is we're retaking the new iteration of it this year to really establish baseline data, since it's so different from the year before, and then use it as part of our redesign of patient safety going forward.
Thank you. And part of what you're saying, just to be really clear, is that the tool was designed to be used for any purpose in any care setting across the continuum of care. So I just wanted to lift that up, because the patient safety structural measure that we've just talked about right now is applicable to acute care hospitals. However, there is a potential down the road that could expand more broadly. Kelly, just put a little bit of a topping on what you're doing with the National Action Plan at Ascension.
Sure. So Ascension is an incredibly large organization with about 140 hospitals, 2,200-ish ambulatory sites of care, and then a series of, or a cadre of senior living facilities. And what we've done is utilize the self-assessment with the leadership teams across the continuum of care in all of those spaces, right? Because it again helps us understand what that infrastructure looks like, and we have leadership in all three of those different care continuums. So we brought them all together to say, in your space, how do we play out? What is the level of maturity that we have from a safety infrastructure perspective based on this self-assessment? We too are in the process of reassessing so that we can understand if the work that we've done to really impact the infrastructure over time has held true and really kind of been hardwired, if you will. So we're looking forward to see how that is, and we will continue to assess because it's a constant journey. And so even though we're taking steps forward, we have a ways to go from a maturity perspective, and we'll continue to walk that journey.
Thank you, Kelly. Craig, I hope we can invite you into the conversation now with a little bit of perspective on the importance of the system assessment from the vantage point of the work that you do with the HHS National Action Alliance. Tell us a little bit more, and you're going to try to pull up a couple of slides now. Fingers crossed,
Yeah.
Magic of technology.
Absolutely. We'll see if it works. First, I wanted to just thank you, Patricia, for inviting me. I wish I could be there in person, but I really appreciate you being able to pipe me in. So thank you for that. The National Action Plan for Patient Safety and the Safety Self-Assessment is absolutely fundamental to the work that the federal government is doing around patient and workforce safety. And you're right, I do want to show a couple slides. So I'm going to attempt to do this here. Let's see if this works.
It's working, Craig, on our end. Congratulations.
Oh, great. I'm glad you can see that. Basically, we've been working really hard in the federal government over the last number of years to align both internally as well as with our private partners, such as the National Steering Committee for Patient Safety. That includes IHI and the American Hospital Association, Leapfrog, Patients for Patient Safety, and many others. And we've been working hard to align to ensure that the patient safety initiatives that we're all working on together are able to move the needle. And we've stood up this National Action Alliance for Patient and Workforce Safety to support this work. And there are 5 aims of this National Action Alliance. I'm not going to go through all 5, but I just wanted to highlight that the first aim, the overarching aim of this National Action Alliance, is advancing organizational safety strategies using safety self-assessments. So once an organization is able to do that safety self-assessment, they can then understand what their safety needs are. The other piece that we've stood up with this National Action Alliance is a website that has a curated list of all of the different federal resources that can help you address the safety needs that you identify using the safety self-assessment. This is just a screenshot of the National Action Alliance website. You can easily find it on the AHRQ homepage. This website also includes webinars that occur monthly where we feature select safety tools from the federal government and different organizations who have used those tools who can tell you about their successes and also challenges and how they overcame those challenges. And all of this work feeds directly into the CMS Patient Safety Structural Measure. We're all aligned closely, and this work is designed to help you achieve all of the goals that are outlined in this CMS Patient Safety Structural Measure. And you'll see first and foremost, Domain 1, leadership commitment, that the executives of the healthcare system oversee a safety self-assessment that drives the safety strategy. So that's a long way of saying the National Action Plan and the safety self-assessment is absolutely fundamental to federal efforts.
Thank you, Craig. Appreciate that. And we'll bring some slides up, I know, a little bit later. So we're talking about why it matters. And I'm curious as we look to our panelists about when you think about a safety self-assessment, like what's the aim? What's the whole reason why you're doing this in the organization. Is about identifying risk, is capturing opportunities. Like, paint the picture of what it's all about from the lens of folks who are really anchored in the day-to-day work of the self-assessment. And you're also in positions where you're communicating the whys.
You want to take it?
I'll take it first. So for us with the self-assessment, the success of it, or the purpose or the why, was all about learning. So when we brought our executives into the room to start to have the conversation around the self-assessment, and the first time we did it within our organization, we conducted the assessment in person. And I will remember vividly for the rest of my career some of the really uncomfortable conversations that we had in the room where a senior leader said, I absolutely know that this work is happening in our organization, and another person in the room said, it absolutely is not, right? And I think, the lesson in that is we are all human. We're humans as leaders, and sometimes our work drifts. And unless we're actively having that conversation and validating and verifying the work that is happening, we don't always know that those things have drifted, right? And so for us, that assessment really helped us identify what those gaps were in a way that a simple number or looking at a metric couldn't help us identify. And it has absolutely changed the way that we organize around our safety strategy within our organization. It even changed the kind of the chronology of the different safety tactics and initiatives that we were rolling out, because it highlighted some gaps that were more important for us to address more timely, maybe than some of the others, right? Because we all know resources are constrained and we can't do everything all at once. So understanding and learning from that conversation was absolutely the success of the self-assessment for us, and has totally informed and changed the way we developed our strategies.
Yeah, and I think that in ambulatory care, harm sometimes is playing the long game. If you're missing a diagnosis or there's a referral issue. So sometimes I think it's easy for leadership to make the assumption, and it's really fair, that if part of a patient safety program is thriving and you're not hearing about a lot of harm, that all of patient safety is doing okay. But the National Action Plan self-assessment brings in elements that you wouldn't just naturally think of unless you were really familiar with it. Workforce safety and well-being, senior leadership job descriptions, having safety at that level in the accountability structure there. So it reframes for us how we view patient safety and what is included in that. And so for me, like you, Kelly, it's more about how we're looking at it and how we're building it up from that scaffolding than the work we're doing on top of it.
Craig, I invite you to add any other additional comments to this whole question of why, the whole purpose. And I know that you've interfaced with many organizations as well on this topic.
Yeah, I guess I'd just quickly say that I don't know if there's one right approach to doing this. And one right approach to framing this. I think an institution can try this safety self-assessment at the system level, at their lowest performing hospital, their highest performing hospital, their flagship. I think the most important point is to just get started on the assessment. And with the patient safety structural measure from CMS, I think there's real motivation and inspiration for healthcare system leaders to support that activity.
It's very true. And so we should talk about let's get started. I know for some of you, it's like, okay, what's it all about at a really high level? And there's a number of freely available resources on the IHI website where you can download this. The organizational assessment tool is online. There'll be customized reports that can be provided for your organizations as well. But let's roll up our sleeves now on how you go about this. And to your point, Craig, different ways to doing it, but let's hear what's worked for you or what maybe you'd advise folks on with some of the learning that you've had with the assessment itself.
Yeah, I like the idea of just get started. So if you're at my leadership level or Kelly's, you can do it. I think something that I learned the first time is because I wasn't at the level where the leaders around me who could make the change were, I had to go up my chain of command. I'd say I had learned and I would advise anyone taking this that's in a similar position to bring leaders to the table early, and not just for awareness or approval to take it, but to build energy and understanding. You know, you can send people links all day. They're not going to read the 10 pages on this thing. So build the energy and really help them to understand how it links to the greater picture. Now we do have the PSSM, where when you and I started, we didn't have that. So already you're out of the gate a little bit ahead where we began. But definitely bring everyone to the table early on for that buy-in.
Mm-hmm. We, the first time we did the assessment, we did it in person, right? So in Ascension, we are organized into regional cohorts, if you will. And so in each of those regions, we brought the senior leadership team together to have a conversation about the assessment to identify where we were. And the first rule of engagement in that was, this is data for learning and improvement. It's not data for judgment. Mm-hmm. And so we absolutely had to have a conversation about we must, in order to develop the strategy and to continue to move forward from a safety perspective in our organization, we have to be honest with ourselves. And so if we're going to use this as a checkbox exercise of, yep, we're good, then we don't need to do it at all, right? Because that's not how we learn, that's not how we get better. And so that led to the second ground rule. When you bring a group of executives in the room to have an honest conversation, you check your ego at the door. Right? And it was, you know, everybody kind of stops and looks when you have that conversation, but that facilitation of it is really important. We're doing the second round of the assessment online. However, right, as we're pushing that out to the executives, we're having that conversation again of, hey, it's time, we're going to reassess, we're tying it to the safety structural measure as, you know, a requirement, if you will, but we're bringing it back to, we absolutely have to be honest with ourselves, and we need your honest impression of where we are on this so that we can continue to learn and drive the journey together. So I think, right, that whole conversation was imperative in the assessment process.
Kelly, can you comment on who's conducting the assessment? Or the different parties that are critical to doing a well-informed and representative assessment at Ascension?
Sure, so we brought the leadership team, so the C-suite from each of the hospitals within that ministry market that we were assessing, as well as the C-suite from our ambulatory team, and so that we could have that conversation together. So we had the chief medical officer, the CEO of the hospital, and then we brought in some what I would call subject matter experts, right? You absolutely want to have your director of patient safety and quality, your director of risk management, patient family engagement at the table, and it was actually the disconnect between those directors and that C-suite where we got the meat of the learning, right? Back to that conversation of, this is absolutely happening, no it's not. And then the dialogue about why it wasn't happening. So we brought all of those leaders to the table and had a facilitated conversation. I am a social worker by training, and that was probably some of the most difficult facilitation I've ever done in my career, but it was really, really worth it. Because we got some really invaluable insights into where we were missing the boat on our infrastructure and our processes.
One of the things that you just said was you engage your patient and family experience partners in this work, and that is, I think, a critical component of what we've spoken about. We have some organizations that have said, well, we'll just huddle with like 3 executives in the room and we'll complete this assessment. That is the total opposite of what, you know, the whole purpose of the assessment and the conversation is about. And on average, in many of our assessments that we've seen with the organizations, and there's a very, very large number of organizations that have been conducting this work, in some cases for several years, the patient and family and caregiver engagement domain seems to be the lower performing of the 4 domains, the other of which are culture, leadership, and governance, workforce safety and well-being, and the learning system. So I really want to lift that up and invite, you know, Angie and Craig, if there's anything that you might want to say again about the importance of having that patient perspective in this work.
Well, I would just say, I love this conversation. You know, having an honest assessment And when I was a chief quality officer previously at University of Chicago, the mantra there used to be get to Gemba or go to Gemba, go to the front lines and really understand, not work as imagined, but work as what's being done on the ground, and really developing inspiration from the improvement opportunities you learn about when you learn of the challenges that frontline providers and patients are facing on the front line. So I like this discussion around this is not a test where you want.
Uh-oh.
Okay, Craig, I'm not sure if you can hear us right now, but you've frozen for a moment. So we're going to come back to you, and we're going to let our AV wizards who are behind the curtain, they're actually the anchors of what happens and goes well and doesn't go well. But it's really, this is not them, this is internet connections. So can you hear us back? Are you back, Craig?
I can. Sorry, I must have lost you.
Welcome back. All right. Angie, how would you like to amplify anything around that?
Well, I think I'll just be really transparent and say when we took the assessment, we found that we didn't have any patients to ask. They'd all gone home with COVID, and we hadn't brought them back into the ambulatory space to be a part of our meetings. So that was in and of itself an identified area of opportunity for us. So we're bringing them back now, which is exciting. Yeah.
We've been picking up on the themes of this notion of work is imagined versus work is done, where we think things are happening and they may not be. And I'm curious to hear, Angie and Kelly, what some of the more surprising findings might have been as you went around and conducted this assessment. Where were some of the disconnects, and what were some of the key opportunities that emerged?
Yeah, I think we had a similar experience to you, Kelly, where the biggest disconnect was what senior leadership thought was happening and then what was truly happening. The patient engagement was one portion where we thought that they were involved and we had brought them back. And then when we dug into the recesses of the organization, we found for ambulatory care we hadn't yet done that. So that was the biggest disconnect. And I think, to be fair to leadership, those areas of the National Action Plan that are like workforce engagement and the job descriptions, I don't think that's on the forefront of everyone's mind. I mean, I know there's a lot of people out here learning about this for the first time. Probably just me saying that, you're realizing like, oh, I actually don't know what's on my senior leadership job descriptions. So it's fair that they don't know, but that is a disconnect that's identified and that we need to help bring everyone into that space so that we can all start from a more robust foundation to grow forward.
One of the surprising things for us was in the culture, leadership, and governance section of the assessment. And it was clear, right, one of the elements is that you have a senior executive accountable for each of your safety goals that's included in your strategic plan, so on and so forth. And we clearly had that identified, right? Every safety goal or clinical priority goal in Ascension has an accountable executive tied to it. However, when we had the conversation to really validate and verify that that executive was driving the accountability and the conversation around that, what we had found was it was delegated. Right, which is absolutely different from what's intended in the National Action Plan self-assessment, right, in the blueprint. And so we had a lot of conversations about what does being that executive mean? And it doesn't mean that you have to be the one to do all of the work, but you are absolutely the one that's staying in tune with what work is happening so that we're not drifting away from the plan or the milestones, and you're holding us accountable to the work that we're doing and the metrics that we need to meet to be successful. The other thing that we found is in that delegation, right, we had a little bit of a disconnect in understanding around the difference between process and practice from a clinical perspective. And so that brought us back to the understanding and the assessment around, well, what is our curriculum for our associates, our leaders, et cetera, on understanding what is patient safety, how you do patient safety and quality work, what is patient safety and quality improvement science, and how are they similar, but how are they different, right? There was a fundamental knowledge gap that we had not addressed, and quite frankly, we didn't know about until we did the assessment and really started to validate and verify the elements within the assessment.
You also, I think, have shared, not only in this with me, but in so many other sessions, that you've uncovered a lot of amazing opportunity. And I was reflecting back on Dan's conversation yesterday about how do we, find the leverage points and target the constraints and the bright spots, and starting with the burst. And so there can be so many opportunities that arise as you do this assessment. How do you figure out what the ones are that you're really going to focus in on, the top leverage points in this whole process? Because we know our world of work is incredibly overwhelming, and there's so many things that we can do, but how do you whittle it to those priorities?
I think that it's important when starting out to triage where you start with where the organization is already going. I think it will then not come out of left field. You can get more buy-in and more energy around it if you move the needle in those areas. It's kind of like an early win. So for me, I look at what are we already doing and where are we moving, and then can I line up any of the elements from the National Action Plan self-assessment with those places. I think that that's also a great way to approach the triage of your improvements if your organization can't put forth financial resources towards improvement. So that's my approach right now in ambulatory care.
We really took a minute to slow down and say the National Action Plan can't be another initiative, right? Walking that blueprint from an organizational perspective can't be another initiative, because if it's another initiative, that implies that at some date, right, that initiative goes away because you've checked that box. And what we really wanted was for this to be transformative in how we do the work that we're doing. And so initially coming out of the first assessment, we really slowed down to say, how do we build this into the fabric of who we are and how we do patient safety within the organization? And that's really helped, right, us from a sustainment perspective. The second thing we did is we said, okay, right, we're lower in the maturity assessment than where we want to be. And so we set goals related to increasing our maturity of our infrastructure over time. So each year that goal repeats itself to say we want to be 1 point better, right? Just 1 point better in each of the foundational areas year over year. And then we took some time to say, what is the work effort versus the impact analysis? So thinking about a grid to say, this is relatively low effort, but will get us high impact. These things are relatively, right, high effort. And then we balanced them over time, because what we didn't want to do was say, we're going to knock out all the low-hanging fruit now, and then next year we can't hit our goal because everything that's left is really high work effort to make that change within our infrastructure. So how do we balance that over time so that we can continuously hit that goal over the next 5 years?
One of the things that we've heard, and your organization, your system is a great example of this, is why do we have to do this safety self-assessment? Because we're already doing high reliability stuff. And I would love for you to just amplify on that. I think that's one of the common responses that we hear, the curiosity that people have, because we don't want to be layering one more thing. The goal here is to align and integrate, which is what we spoke about yesterday, and which is what is happening in so many different levels. But help us make sense of this.
Go ahead.
So from our high reliability work plan perspective, we took a moment to say, okay, within each of those things that we're rolling out from a high reliability organizing perspective, right, because it's a journey, how are we making sure that we're hitting every infrastructure and foundational element of the National Action Plan? So you can take any of those high reliability practices, tiered huddles, executive safety rounds, right? Your serious event review team and governance structure in that, kind of reactive look back of what's happening. And we've said, okay, culture, leadership, and governance. Who's the senior executive accountable in this space? And how are we holding them accountable in that space? How is this information getting into the board? And what we found was that in the implementation plans for each of those different tactics or initiatives, we had gaps in how we were setting it up. So suggesting that we were honestly setting it up to fail from the beginning, right? So we didn't have all of the right implementation components. So we've really used that infrastructure within the National Action Plan to help us make sure that we have essentially a checkbox or a checklist in how we're designing for and implementing the different tactics that we are throughout the organization. The other thing I would say is we teach universal skills or error prevention behaviors to our associates, and we expect them to use those in a daily basis in the care that they provide to our patients. However, as leaders, we need to use those same skills. So the self-assessment, when we talk about retaking that self-assessment for us every 2 years, that is how we as leaders are role modeling, validating and verifying that the work is happening as we intended and designed for it to work.
Thanks. Angie, anything you want to add to that?
That was a great answer. I can't say that I have anything to add to
Okay.
I
But
agree.
bottom line, we're looking at highly reliable practices and the structure and the culture and the leadership of an organization. We spend a lot of time really at the sharp end of care trying to fix people. And what we're really, again, amplifying is the opportunity to optimize systems so that our colleagues who are working in healthcare can do their best to deliver safe care. Kelly, you just picked up on our goal. We want to be 1 point better in each of the foundational areas. And I'd love to transition the conversation of like, how do we know this is really making a difference? Craig, I know that at the national, federal level with the National Action Alliance, there's a couple of thoughts that you want to share with us on that front about how we're making stuff better. The aim of the National Action Alliance has some measures involved with it.
Yeah, I'd love to share that. So one of the goals of the National Action Alliance is to reduce patient and workforce harm by 50% by 2026 from the peak of the pandemic. And we're actually moving in the right direction. And I asked Patricia if I could share a slide or two to show you this. And let me just pull this up here. All right, hopefully you can see that.
It's coming to life. There we go.
Great. So our National Action Alliance had this goal of a 50% reduction in harm. And we all agreed that we need to be able to track patient and workforce safety at a national level and our progress on that over time. And so as part of the National Action Alliance, we stood up a National Healthcare Safety Dashboard. So this dashboard is actually on the National Action Alliance website. And we've partnered with a number of different federal agencies to include patient safety and healthcare workforce safety data that you can track. So for example, we have patient safety indicators that you can track from AHRQ. We track adverse events for hospitalized Medicare patients, and that's a program that AHRQ supports as well as CMS. We track safety measures that you all report as part of CMS hospital reporting programs. And we track patient safety culture survey data from hospitals that we collect nationally. And I just want to show you one example of this. So this is adverse events that occur in hospitalized Medicare patients. You can see our measuring point started in 2021, the peak of the pandemic. And 7% of hospitalized Medicare patients at that time had at least one adverse event. This is data from our Quality and Safety Review System program. And you can see over the last number of years that those adverse events have decreased. And we're almost at a 30% reduction in adverse events for hospitalized Medicare patients looking at 2023 data. We do have a ways to go, but we have a couple of years to get there. But I wanted to share this news as one piece of good news in that safety events are decreasing as we move away from the pandemic.
Thank you, Craig. And we've got so much more opportunity for improvement. And I think Dr. Hickson started out yesterday by saying, hey, 99% of people washing their hands, for example, is not enough. We're really, again, trying to architect those foundational behaviors that we know are essential for safety. I know as our time winds down here today, there's a lot of things that are on our minds. There's so much more that can be shared, and we welcome and embrace the opportunity to talk more with you about this before we finish up. But I want to land on just your reflections. If we were to be having this discussion again 5 years from now, and I don't even want to use 5 years, I'd ideally like to think one year, but Let's be honest with ourselves. Like, what are the kinds of things that you hope will have fundamentally changed as a result of healthcare organizations taking this approach to safety transformation? Angie, can I start with you?
Sure. Yeah, I have my notes because I want to do this justice. I recently read the book Still Not Safe by Kathleen Sutcliffe and Robert Weirs, and I highly recommend it. I know that you've read it many times, Patricia. Towards the end of the book, when it talks about the hope for the future and the way that patient safety can move forward and make significant impact, they say that we need to change from a backward-looking stance to a proactive approach, from just reducing or preventing errors to managing complexity. And so my hope, and we learned yesterday that hope without a plan is a hallucination. So I'll say my plan is to do just that, and I think the NAP maps out the way to have a great launching pad to go forward in that direction.
Thanks, Angie. Kelly?
Yeah, for me, it's that we'll be coming together talking about how we have solidified the infrastructure and the foundation for the patient safety that we all work and do collectively. That foundation will be solid, and as we've done that work, we'll see sustained reduction in harms and see new measures, right? I recently had a conversation with a colleague and said, if we were to band together as organizations and work on something, what would we work on? And one of the topics that came up was CLABSI. We've all been working on CLABSI for a really long time. So in a way, that conversation was a little bit depressing, right? Because here we are saying it's still something we need to band together to work on. And so I would hope and anticipate that we'll all have a much stronger foundation, and we'll be able to share those lessons and those best practices and those foundations across our organization so that we're truly embracing our mantra of all teach and all learn and making a difference together.
Thanks, Kelly. Craig, I invite you to have the last word on your hope for 5 years from now, or perhaps sooner. We're already on a roll here, getting to 2026, I hope.
Well, Patricia, Kelly gave me this opening around CLABSI, and I just have to comment on that for 1 second. ARC has a brand new initiative that we're launching across the country to support reduction in CLABSIs in hospitals. And people can just Google ARC and CLABSI in 2025 and enroll to be part of that collaborative. But my comment about the next 5 years, yeah, I'm hoping that within the next 5 years, it's routine for folks to use the National Action Plan and the safety self-assessment as part of their assessments in hospitals. And I hope that the CMS patient safety structural measure will support healthcare systems in doing that. And that will see extension of these safety self-assessments beyond just acute care hospitals, perhaps to ambulatory nursing home settings and beyond. So thanks for having me.
Thanks, Craig. And I'll just reinforce what you just said, Craig. Even if the PSSM is relevant at this time for hospitals only, and whether you're within or outside of the United States, all of the tools to be able to take this blueprint and turn it into action are freely available. The IHI website is housing all of the materials for the National Action Plan. We invite you to download and share widely and provide us with feedback on what your experiences are and lessons learned to come together in more community to be able to help us do this work together. So with that, I'd like to thank all of you, Kelly, Angie, and Craig, for the amazing partnership and the courage, quite frankly. There's a lot of courage that goes into being able to look under the covers and say, there's some wonderful opportunities here. We all need some social worker skills, I think, along the way to make this happen. But thank you so much, and thank you to everyone for all that you do to lead in advanced safety.